Welcome to the public section of the governing body meeting for Tees Valley CCG. Oh, that's interesting. Karen's turned blue throughout. Amazing. And David has as well. Right, okay. Everybody's being very good and adjusting backgrounds as far as possible to comply with our public recorded meeting guidelines. So remember, this is going to be recorded and will be available shortly. It's being held via Zoom in such a way that members of the public can see us in operation. We did have two members of the public submitting questions ahead of the meeting. Apparently those questions didn't relate absolutely directly to the business of the meeting, but they have been answered. That's correct, is it, Jackie? Yep. Okay. Right. Remember that there's a potential that if you've got something running in the background on your computer that you may inadvertently share it. So ideally turn stuff off. If possible, use the CCG background or Blur or another background if your computer allows it. The vast majority of people are actually using the background. Excellent. I think I'm seeing absolutely everybody who's in the meeting. So if you want to speak, if you just raise your hand and wave it, should be able to spot you. That's great. And if you need to leave the meeting, then turn off your camera so we don't see what's happening in the background. For the public members who are present, there's going to be a opportunity to have questions right at the end. Because I assume iPad is a public member, so because we've got public members present, I'd ask everybody who I'll name individually to introduce themselves and their role within the CCG. So, Karen Hawkins.
Good afternoon, I'm Karen Hawkins. I'm the Director of Commissioning Strategy and Delivery with the responsibility across the Tees Valley CCG for primary care. Okay, I'm Bolesław Posnick, Clinical Chair of Tees Valley Clinical Commissioning Group and also working as a GP across in Hartlepool and the Darlington areas of our CCG. Jean Golightly.
Good afternoon, everybody. My name is Jean Golightly. I'm the Director of Nursing and Quality for Tees Valley CCG. Thank you.
Jackie Keane.
Hello, I'm Jackie Keane. I'm the Head of Governance for the CCG.
Okay, Julie Bailey.
Hi, I'm Julie Bailey, Partnership and Health and Equalities Manager for the CCG, invited today to present 2 items to the governing body.
Mark Pickering.
Hello, I'm Mark Pickering, I'm Chief Finance Officer.
Oh, Mark, you've got your usual microphone problem.
Is that better?
Oh, barely.
Barely.
Oh, that's better now. Yeah.
Okay, I'm Mark Pickering, Chief Finance Officer for the CCG.
Okay, Hassan Tahir. Hassan, you're on mute.
Hi, I'm Dr. Hassan Tahir. I'm one of the GPs who's elected on the governing body.
And Karen Dales.
Hi, I'm Karen Dales.
Oh, you cut out.
I'll unmute myself. I'm Karen Dales. I'm a lay member in charge of audit.
Right. Dave Gallagher.
Hello, I'm Dave Gallagher. I'm the Chief Officer for the CCG.
Michael Horton.
Hi, I'm Michael Horton. I'm Director of Commissioning Strategy and Delivery for Adult Acute Community Services.
Jessica Hollingsworth.
Hi, I'm Dr. Hollingsworth. I'm a GP in the Middlesbrough area and also an elected member of the governing body.
Caroline Gitcham.
Hello, good afternoon. I'm Caroline Gitcham and I'm a lay member on the governing body and chair of the primary care committee.
Andy Mackay.
Hi, good afternoon. I'm Andy Mackay. I'm the independent member for the CCG and I look after quality.
Okay, Alex Sinclair.
Afternoon, I'm Alex Sinclair, Director of Commissioning for Children and Young People for the CCG.
Okay, David Emerton.
I'm David Emerson, Secondary Care Doctor on the governing body of the CCG.
Michelle Thompson.
Hi, I'm Michelle Thompson and I'm the Patient and Public Involvement Lay Member for the CCG.
Hey, Craig Blair. No, Craig may not be able to join us because he's dipping in and out of meetings. So I'll comment on that just now. So Janet Walker and Jean Golightly are going to be dipping in and out of the meetings due to significant other conflicting meetings. And similarly, also Dr. James Nevison will also be joining us at different times during this meeting because he's got other clinical ones to be involved in as well. Lynn Pearson.
Hi, I'm Lynn Pearson and I am the Corporate Secretary taking notes today. Just to let you know, Pos, I've just had apologies from Mike Brealey. He's just sent them through now.
Okay. Okay, and I'm assuming that that's everybody from the CCG side who's attending the meeting. I'm assuming that iPad is one of the members of the public. So iPad, if you'd like to introduce yourself.
Hi guys, I'll turn my video on. My name's Jonathan Simpson. I hope you're all well. Good to be on Zoom.
Yeah.
Yeah, I came as a member of the public today, but I do work in the pharmaceutical industry as a healthcare partnership manager for Norgine. And having been away for 5 months with the way it's been, Tees Valley CCG is new, so I was really keen to see what the objectives are and everything driving forward.
Okay.
So thank you.
Yeah, welcome.
I'll go back on mute and turn myself off again.
No, it's okay. Just on mute like everybody else, but same for everybody else. If you wish to speak, that's everybody in the meeting, so I can see you all. So if you want to speak, just wave your hands. Okay, so running through my agenda. Okay, declarations of interests have been sent out with the papers. So anybody got any extra declarations of interest that we should note or that you feel we should note in relation to the items on business? Opportunity to flag those? No? Okay, so that's noted. Right, okay, so moving on to the minutes of the previous meeting from the 22nd of July. So page 8 of the pack. Page 9, page 10, page 11. Okay, so any items from that to note or not covered by actions? Right. Okay, okay. And now moving on to the action log. So we've got one complete. That was the patent of public involvement update. And we've got one open public governance and assurance report. Jackie, do you want to sort of pick that one up?
Yeah, the composite report that we refer to is actually coming to the governing body in November. I think there's just a little bit of confusion. The report about decisions went to the audit committee at the last meeting, but the composite report about the progress against COVID and reviewing our actions against that's coming to the governing body in November.
Okay, so we can close that one off now because it will be coming to the governing body as a definitive item. Yep.
Yeah, okay. Do that.
Lovely. Okay, for decision. So you'll note that we've got slightly different order of items because often we'd have Chair's report here verbally, but that's been sent through as an absolute paper for people to note. So next one is the review of Quality, Performance and Finance Committee and the Executive Committee. Over to you, Jackie.
Okay, thank you. I think that the paper in front of you is fairly self-explanatory, but just in summary, what we've been trying to do is improve the way that the committees operate so that we can ensure the delivery of robust and proportionate arrangements in terms of discussions about quality, ensure that we can allow more focused discussions and deeper understanding of relevant issues. By doing that, we intend, if the governing body are happy that we do it, for the Quality, Performance and Finance Committee to be separated out so that it focuses entirely on quality issues, and that would also include patient experience, and the performance and finance elements of the current QPF committee move into the executive committee. That will hopefully also remove some of the duplication that currently happens, while still ensuring that the quality committee has an overview to allow for contextual understanding relating to performance of finance and any impact that might be having on quality. Also, it would hopefully be one of the first steps in terms of introducing a more system-wide quality assurance committee. And if the governing body approve the revised terms of reference that are in front of them, then we will be intending to contact the provider organisations and ask for a nomination from them, and to be full members of the committee, not just attending the committee, but to be full members of the committee. So the attached paper outlines that general approach, and the revised terms of reference. We've kept them track changes that you can see for transparency purposes, what has changed and what has moved across. So really, if there are any comments or queries, more than happy to take those. I know that in the previous QPF committee where it was discussed, David Emerton had asked for an explicit statement about the contextual element about performance and finance being included in the committee, and we've taken that into account and included that in there. And Janet Walker, I don't think Janet's with us at the moment, but she's confirmed that she's happy with the approach as well. So more than happy to take any queries.
Okay, so anybody want to, Jean?
Chair, if I may just bring colleagues' attention, and apologies that I haven't picked this up sooner. Under 2.1 membership, I think we need to be clear, we've got nominated individual from ICP Provider Trust. We're actually going to be looking for individuals from each of our, so just in case anyone thinks there's going to be one person on behalf of all the other trusts. And equally, we've yet to resolve, because the desire is to take this to an ICP approach. Our ICP is not just made up of the NHS. So again, this will probably be iterative, but how we get representation, and we would anticipate that that would be singular person, for example, on behalf of our hospice colleagues, because we have a number of hospices across our Tees Valley, and equally our independent sector hospitals, because again, we have a number of those. So just to bring that to colleagues' attention.
Okay, that's noted. I had a hand from Dave and I had a hand from Caroline. So Dave first, then Caroline, and then Michelle.
Thank you, Paz. And probably just to amplify some bits that are in here, this is a really big opportunity for us to do two things. One, to get a more tight focus on quality and the breadth of quality. That doesn't sound too much like an oxymoron. But equally, to involve partners, and all of the NHS chief execs have signed up to this. So if we agree it today, I'll write out to them and ask them to nominate executive leads. So it'll be somebody from their boards who will attend this. And Jane's right, it's a bit like the layers of an onion. So we'll start with this relatively small, but we can build on this as we build up the ICP approach. So we have a really good, hopefully doing it once approach to overseeing quality and safety across the whole of Tees Valley.
Okay, thanks. Caroline?
Yeah, I wasn't conscious that the QPF covered primary care originally, and so I'm just wondering how this will fit with the primary care committee, and if there's anything that we need to take into account in relation to that.
Who wants to pick that up? Jean?
I'm happy to, Karen. I don't know if you want to go first or... I think it's key, Dave's point in terms of really we're looking for an iterative. We need to get this off the ground. We need to get this working. I think that the diversity of it, of membership, helps with the assurance and the rigor of the assurance. And I think as we take an ICP approach, primary care is absolutely integral to the provision of healthcare across our ICP. I also think that on the back of COVID, we have a golden opportunity to capitalise on that in terms of the improved understanding that our provider trusts have of both the breadth of primary care, the value of primary care, and some of the pressures and challenges within primary care. So again, that would be something that we desire to, but I still think there is a very robust CCG quality committee at the minute, specifically on primary care. I don't know if you want to say anything about that, Karen?
Yeah, thanks, Jean. Yeah, just to reassure you, Caroline, the primary care committee and its functions, because those are delegated functions, will still remain with the committee, and the quality and variation group that works below the committee will still remain in place, with a particular focus around our delegated duties. What we'll do in the other committees, we would take the reports that we provide through primary care committee into the quality committee, but we would also ensure that it picks up the wider scope of primary care, because primary care actually deliver community services as well as the delegated functions that they deliver on our behalf. So we'll tie it all together to make sure that, one, the system has a view from a primary care perspective, and it's absolutely fed into that, because there are quality concerns that may be raised in trusts that actually impact on primary care and vice versa. So it's trying to bring that systems approach together in that committee, but certainly under the primary care committee and the quality group that's already established, those will remain.
Yeah, that's. I just had another point on 9.1. It just talks about due to the sensitivity of information being discussed, all papers will be treated as commercial in confidence, but the minutes of the meeting will be submitted to the in-public meeting of the governing body. And I just wondered how that would work. Will it be redacted?
Would you like me to?
Yeah, please, Jackie. Yep.
Yeah. As you know, Caroline, in the past, the minutes of the QPF meeting haven't necessarily always come into the in-public meeting of the governing body because of the level of the detail within the minutes. That sometimes is because the level of detail in the papers might not have been sufficient, so therefore it's been part of the verbal updates or the discussion of the items. As part of the work that we did a couple of months ago in terms of transparency, what we agreed was that the level of detail contained within papers would allow for the discussions to be held, but not having to drill down into absolute detail, that the information would be there. But we do feel as though it's incredibly important that the relevant areas of those conversations are put out there into the public domain. So we will make sure that we've got that very good balance across the two, really.
Yes, it makes sense, because because of the change of the committee arrangements and the fact that we really try to do as much of our business in the public domain as possible, this then facilitates with our sort of like strategic view of our ways of working. Okay, Jean, you wanted to come in there?
Yeah, I think key in what Jackie's saying there is about the balance, because if we get this right, which we're aiming to, we're going to be very transparent and candid, but actually what we want to do is not add to the workload of other colleagues. So for example, they will be able to present their internal papers that they are using for assurance, rather than having to redraft papers to submit to us. So it will be something that will take a bit of work around about the minutes capturing and reflecting the conversation in a transparent way. Whereas, as Jackie said, some of the documents that underline with the specific evidence around about insurance or detail of issues of concern or incidents, we'll just be mindful of that.
Okay, thanks. Michelle?
Yeah, it was just to say that I'm pleased that there's more of an emphasis in the terms of reference on patient involvement and experience, because I think those go hand in hand with quality and safety. So I was pleased to see that there was more in it. So thank you.
Okay, lovely. So we need to approve, presumably, the changes to the terms of reference and the structure of the committees. Is that right, Jackie?
It is, yeah.
Yeah. Okay, so everybody happy to approve those? Yep, nods all round. Yep. Okay, so that's approved for the changes to the structure of those committees and the terms of reference. Yep, and there's a thumbs up from Jessica. Okay, lovely. Right, right, juggling computers. Moving on. Now, the Workforce Race Equality Standard Summary Report and Action Plan. Julie.
Thank you, Chair. So as one of the largest employers in England, the NHS has made a commitment to ensuring that its workforce is representative of the population it serves. So as a CCG and employer, we're only a very small part of the national NHS workforce. It is also still important for us and our communities. The RES report, the Workforce Race Equality Standards report, reflects the workforce of the former CCGs, but this workforce has transferred into the new CCG, so it's very much reflective of who we are now. While it's true the Tees Valley population is largely white, especially in our local authority areas other than Middlesbrough, we would still expect, if we were truly representatives, to have some more diversity within our workforce. And I guess this is what the RES standards help us to understand. We do have representation and some diversity with our clinical workforce. And Dr. Walker, our medical director, was asking where our clinical leads feature in this, and they're in that other column in the clinical charts. However, our non-clinical workforce is predominantly, if not exclusively, white. We've also found out, through looking at the RES data, which is part of its function, that we have very few applications from members of our population from Black, Asian and minority ethnic groups. The report summarises the data that's been largely extracted from our HR and NHS job systems, and this has been submitted to NHS Digital as part of the national return. I've suggested some actions in the action plan that accompanies the overview paper that could possibly help us move forward, and I'm keen to get the governing body members' views on whether they feel this is the right direction and might help us change our workforce profile in years to come. There is an action in there as well around identifying a governing body champion for equality, diversity and inclusion. But before we get into the discussion, I'd just like to reassure the committee that this isn't all the work we'll be doing around equality, diversity and inclusion within the CCG. This action plan is very much related directly to the RES standards. We will be doing work through the people plan, and we will come on to that later in the agenda, and our equality and diversity strategy and objectives. So I'm asking, in addition to any feedback from the governing body today, approval to identify outside of the meeting a governing body champion, and I'm seeking support to publish this report on our website in line with the requirements of the RES standard. I'm happy to take any questions.
Okay, David first. Yep.
Yes, thank you for the report. I think it's a good report. My only concern is that this springtime there's been so much focus on the tragic deaths of health workers from the Black and minority ethnic community, and the whole issue of health assessments and whether people were working in the right place. And just thinking that if people read this as it is, without any sort of cross-link, maybe there could be some sort of just cross-reference or a hyperlink to the next document, the NHS People Plan, which is excellent and deals with all of those issues. I wouldn't like sort of people just to read this in isolation and think that we weren't mindful of what's been happening this year. And I mean, that could be done either just by mentioning in the actions or possibly just a footnote and either a hyperlink or directing people in that direction just to reflect what's been happening this year, perhaps.
I think we can do that, and we can look at how we put them together on the website as well, so we can demonstrate the clearly.
Thank you.
Caroline? Oh, sorry, Dave after Caroline. Is that all right? Yeah, Caroline.
Yeah. I just just an indicator that stood out particularly on page 36, that 22% of staff experienced harassment / bullying. I noticed that that's lumped in with some staff feel there isn't equal opportunity for career progression, but I just think that is a bit of a worrying statistic, 1 in 5. So I just wondered if something could happen in relation to that quickly in terms of the 22%.
Okay. Over to you, Dave. Julie?
Yeah, I was just going to say this relates to the listening exercise work that we did. So I think the next stage is to reflect on what that's telling us as an organisation and take forward some of those actions, and we can share those with governing body members.
Okay. Yeah, Dave?
So just to add to that, this is an historical thing, so it's picked up where we've been. There's a piece of work that we'll allude to later on about working with the staff to try and find, a bit more detail on this, but then to work to make sure we avoid this, because you're absolutely right, Caroline. And the other thing I just want to amplify David's point, which is really well made. This is of necessity almost a standalone response to a document. There's a much bigger piece as part of the people plan, and indeed as us as commissioners in terms of commissioning services linked to the tragedy we're seeing with black and ethnic minority people over the last few months. So very much we need to get into that, and I think key to that is having a governing body lead sponsor, how you want to describe it, champion, that as Julie says, we'll pick up offline. But I think if we can commit to that, it's a big move forward. But you're right, Dave, it's a whole package rather than just a one-off paper, this. Thank you.
I've got one observation in relation to the numbers of BME applicants for roles in the CCG. Is this to a degree a historical relic of the fact that we've gone through several reorganizations of the CCG, which kind of sort of limited the pool of potential applicants to people within the CCGs that we were reorganizing from? Julie and Dave.
Potentially, that's a good point, Pos, that I hadn't thought about. So yeah, that's something we could look at and cross-reference it with previous years.
Yeah,
I hadn't thought about that.
Yeah, I think that's a good point, Pos, and I think that's why we get into the work looking prospective to see what we do about this, which, if that's the case, it should be easier to want to make a change and to demonstrate that change.
Yeah. One last comment is identify good practice approaches from local authorities. Are we sort of unnecessarily limiting ourselves in relation to good practice ideas? Is there a wider pool of organizations that have been successful at good diverse recruitment that we could be looking for ideas from?
I think so, Pos. Yeah, I think local authorities have been progressing this work. They are better at getting a broader range of applicants. So I think there is something we could learn from those colleagues.
But are there any other organisations that we could be learning from that are equally good, if not better, than local authorities? Just worth sort of casting the net a bit wider if we're starting from afresh, so to speak.
Yeah, absolutely. You're thinking non-NHS organisations?
Yeah, commercial ones, voluntary sector ones. Michelle may have contacts that would be useful as well.
Yeah, I can take that as an action.
Yeah, it's something that I've spoken to Julie about, as well as the patient and public involvement. So there is an emphasis on the fact that we don't really engage with BAME groups anyway. So, as well as for staff, it's also the same for engagement.
Okay, so anybody else? Any last comments before we move on? No? Okay, so that's noted. We're endorsing the action plan and got a few suggestions for some slight extensions to that. Anything else you want from us, Julie?
No, that's great, Chair, thank you.
Okay, lovely. So moving on next to the linked NHS People Plan.
Thanks, Chair. So hopefully people found this a useful summary and a good introduction to the recently published People Plan. The purpose of bringing it to the governing body today was to ensure that you're aware of our responsibilities as an employer and as a system partner in delivering this plan. You'll note some of the work needs to start fairly quickly and will be supported in this by our commissioning support unit in many areas, but we've started some of this work already. The res discussion that we've just had about taking inclusion seriously, and the conversations that we're already having and have been having with our staff about working in a more agile way, not just now but for the future. The action plan included highlights some of those immediate actions, and you'll note there's a requirement for the CCG and the ICP to develop local people plans. There's a need for a non-executive wellbeing champion, another champion. Again, I hope we could agree outside of the meeting today. The move to being a more flexible employer and that significant focus on inclusion and belonging. And just to say, that's not just the areas we've touched on in the res report, that's around inclusion in the fullest and broadest sense. There's further actions ahead, and there'll be some specifically for governing bodies and leadership teams around diversity and inclusion and competency frameworks as well. And as soon as we know more about that, we can share with colleagues. So the ask today is that I can work with you, Chair, perhaps on identifying a champion outside of the meeting. But otherwise, I ask the governing body to note the work underway, the work that's ahead of us, and ask for your support to help take this forward.
Okay, so any comments or questions from anybody there? No. So we support yourself and accept the report, and then we'll sort out the champions out of this meeting once people have had a chance to consider the opportunity to have these interesting roles. Okay, so we'll report back on the filling of those roles briefly in the next governing body meeting then. Okay, right.
Thank you.
Okay, that's noted. Next one's my report as a sort of formal written report. I'm not going to run through all of this, except to note that we are now recording for the purposes of actually putting this out to, in the public domain, as opposed to previously reflecting on this as our personal development, how we performed on recording. I do want to formally note for the record that general practices have been providing general practice services since the 23rd of March, despite what may be the perception in some areas in the public domain. And they have been working at significantly different and challenging clinical circumstances, and they have been doing the return to normal in equally interesting and different circumstances because of the fact that secondary care has been having to work differently. So just to note formally the contribution to healthcare in the Tees Valley provided continuously by our member practices since the 23rd of March. Okay, and that's all from my report, unless anybody wants to ask me any questions. No, just receive the report. Thank you very much. I'm going over to Chief Officer's report. Over to you, Dave.
Okay, thank you, Chair. And taking your lead, I'm not going to go through this in its entirety. I'll probably just pick on a couple of things and maybe add a couple of bits and pieces to it as well. So the COVID response bit, just wanted to share with governing body that there's a national people pulse survey that takes place for the NHS. We're very much participating with this, and it's quite a quick survey to fill in for staff. It takes about 5 minutes or so. We're starting to get the results back of some of that, and we're feeding that into some of the work on the Back to the Future group so we can understand how staff are feeling, what extra support they need. And once we've had a couple of versions of that, we might actually bring it back to a governing body, maybe to a development session, just to share that for information, but it's quite a useful thing. The other bit on COVID response, and it kind of follows on from your comments about the system and how they've worked and coped. And again, thank you to everybody who's done that. As I think colleagues know, we're hitting a point where the infection rates are increasing. As somebody who lives further north from our patch, we're under different type of lockdown arrangements to when I'm at work. The really important message that we will try to get through is that the support for the NHS was fantastic in terms of people coming to the doors and clapping of an evening. That was great. The public really, really needs to support us now in the NHS by actually adhering to the rules and the guidelines, because there's a real big opportunity to stop the virus transmission getting worse. And we definitely don't want to end up in a position where with the hospitals, but also primary care being almost, but not quite overloaded as we go forward. So my personal ask, that I'd ask from the organisation, would be that local people actually listen to the guidelines, understand them and adhere to them, because it is really, really important. And I think we've all seen examples across the northeast and the country of people apparently not adhering to those guidelines. So we need to do as much as we can to support that. Having said that, the rest of the report looks forward to the future and reflecting really we're halfway through our first year as an organisation, which is scary. We're getting to grips now and starting to develop how the organisation will work. We've had an example already in discussing the quality committee. We're starting to work with staff, and we've got a staff event coming up soon that we'll use via the medium of Zoom or Teams to get into how we work differently as a new combined CCG, which will help us get into some of the work we probably would normally have started 4 or 5 months ago, but couldn't. Within the systems piece as part of that, we're starting to make some progress on an integrated care partnership Tees Valley approach, and we're starting to put some of the systems and governance in place, not least because of which, and Mark might touch on this when we come to the finance report, increasingly any money that comes into the system will come into the system and not go to individual organisations. So we need to get geared up for that, and the quality piece we talked about as part of that, finances part, and others are, so more of that in future meetings. And probably just wanted to leave this with saying that we've got buy-in and support from the councils working together as 5, and we'll see how we can do 2 things. 1, work as well across Tees Valley, the strategic commissioner piece, but 2, just as importantly, how we get reach into working with 5 quite different councils, local authorities, but we need to do both of those. So we're doing some work with directors that we'll share with staff about how we get into that a bit further. But that's probably it for me. Happy to take any questions or comments though, Paul. Thank you.
Thank you, Dave. Anybody want to add to or query or seek clarity? No? Otherwise, we'll receive Dave's report with thanks. And then we'll move on to the locality update. Now that's from Janet, and I've got that. I needed to briefly unmuted. So I'll read that out because it's a verbal report, but she sent it to me via email. So if you bear with me. Dear governing body members, many apologies for not being able to attend the full governing body meeting today, as I've been called to another urgent meeting relating to our COVID Care at Home programme. Over the past 2 weeks, the Clinical Commissioning Group has held a series of locality engagement events with practices across the Tees Valley. Similarly to earlier engagement events during the pandemic, we held virtual events on Zoom. As a CCG, we continue to recognise the need to maintain open 2-way channels of communication with practices. And in addition to our weekly primary care bulletin and the Friday Blue Bulletin, holding events as close to face-to-face as we can was an important approach to link with practices. Practices are continuing to work very differently, but remain open. They have never closed and are following the total triage approach as outlined in the NHS guidance and standard operating procedures to keep patients and staff safe. The events acknowledge this ongoing determined approach by practices, recognise the hard work and the challenges, whilst emphasising that we continue to work in an area of huge health inequality with outcomes that we need to strive to improve. The engagement events covered the requirements of COVID phase 3, including the ask of general practice to return to as much pre-COVID activity as possible, reaching out to those whose care has been delayed by COVID and other vulnerable groups, address backlogs of cervical smears and childhood immunization. With increased incidence of COVID and other respiratory viruses, practices have been experiencing continued workforce pressures with staff self-isolating and testing for primary care staff to increase systems resilience was discussed. Pathway and service changes required due to change ways of working across primary and secondary care were discussed. Preparation for winter with the arrival of flu vaccination into practices. Flu vaccination campaigns are starting and the importance of these programs was also discussed. Practices received an update about the COVID virtual ward or COVID care at home, the service run by an alliance of our 3 GP federations to monitor patients with COVID at home in the community using pulse oximetry and a digital app to record the readings as part of a NHS England pilot to determine if you can determine effectively identify deterioration earlier, intervene earlier and improve outcomes. Session was concluded with a question and answer session. The final session was yesterday and action notes, collated slide packs and questions answers will be available shortly. In addition to engagements events, we held our first clinical round of Council of Members meeting with all member practices across the Tees Valley on Thursday, the 17th of December. And once again, the meeting was held virtually via Zoom. The meeting was chaired by James Nevison and was well attended by practices. The member practices received information relating to the annual report and accounts, as well as discussing the terms of reference, structure, and the shape of future meetings. So there you go. I'm happy to answer questions on behalf of Janet, and James isn't here yet, but he may, if he joins us, answer questions if necessary. And I see a hand up from Andy, and then there's Karen as well. So Andy first. No, no, that's not working. Okay, Karen.
Yeah, thank you, Chair. It was just to reassure the governing body, on top of what Janet's provided, is that we're also still undertaking the sessions where we attend the practice manager meetings in each locality. So we attend those on a monthly basis with the practice managers to gain any insight and also to provide further briefings to them in relation to primary care. We also have monthly, across our 14 primary care networks, we have monthly meetings with our primary care network clinical directors, and we undertake engagement sessions with them, which are separate to the wider CCG engagement sessions and based mainly on operational work and the continued good work within general practice, and them coming together as networks in relation to the network delivery of services, which does include flu as we move forward as well. So there's a lot of engagement continued with primary care throughout the period of COVID. We met with primary care on every 2 weeks during the peak of the pandemic through March till June, and we've moved that back to the monthly meetings now, and those will continue, and we'll continue to engage through the practice manager meetings.
Thanks, Karen. It's interesting to note actually that our Council of Members meeting was enormous. There were about 63 attendees. I mean, we've got a large number of practices, but we were easily core at that meeting. So that was encouraging. And it was very nice that James, we actually had not myself chairing the Council of Members. One of the other GPs chaired that, and then we hopefully will roll that out to being sort of like a shared chairing arrangement with the other localities, and thus sort of reinforcing our locality representation in the Council of Members. So anybody else got any questions? Andy, you've still got a hand up. I don't know if that's meant to be there or not. No, okay, right. Okay, so anybody else want to ask questions for the clarity? So we'll receive that report from Janet and the clarity provided particularly by Karen. Okay, thanks a lot. Okay, so moving on to patient and public involvement update from Michelle, which once again we've received as a paper this time. So Michelle, anything you want to flag for us from that report?
I think really it's just to say I'm really pleased that it is a written report now, because to try and fit everything in 5 minutes is usually a challenge. So really what I wanted to do with this report was just give governing body members a snapshot of what is being said across the Tees Valley. So obviously there's the all of the Health Watch is in there, but also Health Watch England as well, because they often publish reports that where they've found out patient and public views and experiences right the way across England, and it's just how that relates to Tees Valley as well. The communities of interest is following on from the comms and engagement strategy at the last meeting. So the communities of interest concept was always going to be more of a digital concept, but also alongside that face-to-face engagement as well, so that we were trying to include everybody. But obviously over the last 6 months that has been non-existent, so that has brought itself, it's also brought challenges itself because of that. So we're very aware of the BAME communities, and also people that just are not on the internet, that just don't engage digitally. So I'm really pleased that we've got a communications and engagement officer, because they'll be able to help with the operational plans going forward. And then also it was just a quick update on, you know, sort of meetings that I've been attending, which are all digitally focused as well. So I think really for these reports, it's just whatever governing body members feel is valuable, then please feedback, and then I can start to include that as well.
Okay, Jean.
I would echo Michelle's points. I think it is really helpful to actually get the feedback. I just wanted to bring colleagues' attention to the point at the bottom of page 79, which was from the word on the street. I think we need to take on board, because it's talking about the telephone consultations, And under Dr. Walker's update around the locality, we're talking about the national guidance about the triaging and the telephone triaging. I think obviously we probably need to work a bit more on our public's understanding of that, because it is difficult for people, but it is national guidance. I just wanted to sort of connect the two reports so people were aware of that. Thank you.
Okay, David?
Yes, thanks, Michelle. It's an excellent report. I was just wondering, on page 77, we've got two doctors referred to by name, Dr. Roberts and Dr. Yeomans, whether we would normally do that or whether those names should be removed before it sort of goes on a website, or at least sort of ask their permission.
Okay, can I just pick a item from that? I thought that report specifically naming those two doctors was very positive, and I suspect that may be why names are actually left in.
Yeah.
But I think it probably would be prudent just to double check that they're happy to be actually named in any minutes.
Yes.
Thanks.
Yeah, I would agree with that. The reason that they were left in was because it was positive. But you know, sort of some of the things that I've included in there, I have anonymised all the way through because there was a lot more information that I received. So yeah, that's a good point.
Aaron?
Yeah, I would just like to say the report was really well received, and I think it's given us some insight in terms of that soft intelligence from our patients in public in some of the areas that we need to address, and certainly in relation to communication. Jean quite rightly pointed out around the national direction, but unfortunately I think patients don't understand national direction or directions, and that's where we need to be able to support the communication and that engagement of patients. And certainly that prompted us, Michelle, in terms of your report, in relation to some of the key messages that have gone out over the last week in relation to GP practices are open, they've always been open, but the ways of working of GPs now as we move forward will change, and some of those changes will be sustained beyond COVID, and that's absolutely where we need to get the messages right with our patients and our public to make sure that they understand that in an easy way, and what that means for them. So really well received and has prompted some actions internally in terms of being able to take that forward, so thank you.
That's really good to hear. Thank you, Karen.
Karen, just to pick up on some parts of the report have numbers of instances of different areas where patients have had negative experiences of the healthcare process. Can we be assured for the governing body that we have got an effective system in place in the background for anything that Michelle picks up, for that to be fed back to relevant providers or trigger the relevant processes that may need to be triggered?
Yes, and I think that's one of the things Michelle's quite rightly picked up in terms of the engagement officer POS, and how that engagement officer can link with the wider directors within the CCG to ensure that soft intelligence is fed back through. Often when it's in relation to complaints, we have sight of those anyway because they get sent through the complaints team and to the relevant directors for action and response. But there's some of the word on the street that Michelle included in the documentation that we wouldn't be aware of until we'd received the report, because we don't have that direct contact with patients, which has been really beneficial to take some action. And it may be that sometimes we don't need to take action, but we need to be cited on it to build that into our plans as we move forward. And certainly from the reports that are presented at governing body, we can use that intelligence to inform that also.
Yeah, Jackie?
I was just wondering there, just listening to that part of the conversation, because obviously the governing body meets on a bi-monthly basis, and some of these things will be coming through to you earlier rather than later, Michelle. I was just wondering if sometimes the word on the street, if we're aware of it, if we're able to be actioning that prior to receiving it via the report, and then it might be that we're able to even use it as a bit of a learning, you know, a you said we did bit. We could add to the report and have it as a sort of like constructive story about what we've done as well.
Yeah. I do I do like that idea, and I think one thing to say is that with the intelligence that I've received from the health watches, then obviously they have their own reports and things that they'll be sending to commissioners and providers. But I think one thing that that I would like to see as well is more input from voluntary and community sector organisations, so more of that specific conditions and illnesses and support groups and things. So I think word on the street from them as well. So I think there's a lot more that could be put in there just to give that bigger picture, but more on a monthly basis. So then, as you said, you know, then we can sort of condense it for the quarterly reports.
Okay, thank you. Michael, you had a hand up. Oh, sorry, Karen. Michael next, and then you.
Yeah, thanks, Pos. I was just navigating the hand. It was just to say, from an acute and community provider trust, the feedback on the word on the street and the particular patient stories in there are really helpful. And just really to assure a governing body, we have got mechanisms. So we have got discharge meetings with trust colleagues and other colleagues where we can pick those things up. And we have got work on specific pathways that we can pick up. So the example are related to urology is an area that we could particularly pick up as well. But it was just to provide that assurance and how helpful these really are, and the fact that they're included in the report is really welcoming.
Thank you. Karen?
It was just picking up on the point that Jackie raised, Chair, in relation to how we ensure that engagement with the more up-to-date information. We did have a meeting with the voluntary sector, and it's been agreed that Julie Bailey is our CCG point of contact for the voluntary sector to feed any soft intelligence, to have meetings, and she will bring in any relevant director leads or portfolio leads to be able to respond. Also, our health watches all utilise access through Julie to raise any concerns that are imminent concerns that need to be dealt with immediately within each of the portfolio areas. So Julie's our key contact with both Health Watch and the voluntary sector in relation to any patient concerns or queries that might get raised that don't come through as a complaint but need to be addressed in terms of experience.
Okay, thanks. Michelle?
Yeah, I think I need to be aware of what those things are as well, so that I'm not duplicating on things, because we just need to make sure that there's no loose ends. But no, that it's good to know that Julie is that contact for the voluntary and community sector as well.
Okay, so thank you, Michelle. The contents of your report noted. Particularly noted is the fact that there's positive reports of outcomes of healthcare, because there's a vast volume of very good healthcare going on, both, you know, in all the sectors that we commission. And it's nice to positively note an experience of that vast volume of great healthcare that we get provided for us. Thank you very much. Okay, right. So that was patient and public involvement update. And now moving over to Mark for the finance report for the 4 months ended 31st of, oh, sorry, Jean, I missed something.
No, Chair, you didn't miss anything at all. May I just politely repeat my request for a slight agenda juggling, because I do need to join a national call at 3 o'clock.
Oh, sorry.
And I do have,
sorry. Yeah,
so if I may.
Absolutely.
Yeah, if I may, Chair.
Jean. Yeah, apologies, Jean. I've been working from possibly a slightly out-of-date chair's agenda sheet. So, yeah, apologies. Yeah, so over to you. We'll juggle the agenda. If that's okay, Mark, can you cope with that? Yeah, okay, lovely.
Very sorry.
Over to you.
So, I've actually got 4 papers, but I'm just proposing to do the quality one at the minute, and then I'll come back and talk about the others later, because they are actually for information, if that's okay.
Absolutely.
So, this is a really effective way of getting me to be very brief as I go through the paper. Give me 4 minutes, so I salute your strategy, Chair. Colleagues have had the opportunity to read the paper at length, so key things I wanted to pick up on, but as always, take any questions. You'll notice that I've raised concerns about the number of serious incidents that have been reported and those numbers going down. For completeness, I've put the figures in for all of our providers. We do monitor this very closely, because obviously there are a number of ways of looking at this, but a high number of reporting is often taken as an indicator of a very positive patient safety culture approach. There are some reasons that we could think why the numbers are going down because the activity's gone down, but we're watching that very closely and waiting to see if there's a delay, if there is a tail to this dog. Also, just to comment on the fact that the infection prevention control guidance that we're getting from the national colleagues is very iterative. So we are sharing that as quickly as we possibly can. Sometimes there are some areas where we require further clarity as we pass that on. So we're very closely linked. That has an impact for both our providers in terms of trusts and delivery, but also our primary care colleagues as well. So a lot going down there. You'll notice in this report that there's quite a strong focus on the independent sector because we routinely cover our NHS providers an awful lot. This is in keeping with both the work that we're doing. It's also in keeping with the way that the system has flexed, and this is the whole system flexed to support and provide care to the whole population that we serve. You'll see that there is quite a bit of detail about BPAS, and that is work that is ongoing that we're closely linked into. In terms of safeguarding, we do have some really good news. We have a new chair for the Tees-wide Safeguarding Adults Board. This is a gentleman who's a Mr. Darren Best, who is, in his words, a borough lad. So that is good that he is familiar with Tees. He is a former police officer, so he is not just familiar with the locality, but he's also very familiar with a number of the challenges that we all work very hard to address. And some good news around our Tees-wide Safeguarding Adults Board. We've had a recent meeting where we've linked very much with the community safety partnership, because you'll see in this document a tremendous number of the issues in relation to domestic homicide reviews. There is statutory responsibility sits with them, but actually we want to make sure that the learning is disseminated as widely as possible. You talked about the homicides, and then latterly we've got, as we always do have, we've got the learning disabilities patient numbers. These are just for anyone who wonders why this is what was formerly known as the Winterbourne View cohort, Concordat, became the Transforming Care programme, which is a very vulnerable, potentially very vulnerable patient cohort that is very high in our priorities as well as high in the annual priorities for NHS England. Later on the agenda, I will be reporting in relation to the LEADER mortality review, which is the review into some of these patients who die, any key areas that we're learning from that. That's literally a whistle stop, but I'm happy to take any questions before I depart, Chair, and thank you for your indulgence.
Thank you. How long have we got for questions for yourself, Jean? When do you need to leave?
Well, as long as you need
now.
me for, Chair, I'll just join late.
Right.
This is important, okay. So I need to answer these questions first.
Okay. Anybody questions for Jean? Observations? While people are thinking, there is a little bit of flagging of the shimmy mortality banding for CVDFT. What's being done to monitor that, and anything you want to sort of further feedback to us?
You'll recall, Chair, when we had issues, concerns with the high number at North Tees and Hartlepool Foundation Trust, we have a very robust system that swings into play around about monitoring, not just monitoring, understanding what's informing those numbers. Just for anyone who's new, mortality metrics remain a very contentious area because they are influenced by many different factors, which is why we spend a considerable amount of time getting underneath them. So it's flagging, and we are looking at it, and of course we have the CQRG, but also we have our other ways of linking with the trust to get underneath those numbers.
Okay. Good. Anybody else? No. So doubtless the SI's reporting and the reporting culture is under ongoing scrutiny and review, and indeed the new quality committee structure will help with the monitoring and then feeding up to governing body.
I think I've put them in here this time, Chair, because there's lots of things that we do in the background, we do as routine, and we only bring them exceptionally here. I had some concern in relation to one particular provider, but there's always helpful to give you context relative to the other providers so you understand the number, because otherwise it just looks like you're picking on one particular person. It's interesting that the numbers are going down. We could think that we could just attribute that to COVID, or we could look further and understand, is there something specific? There will be certain generic issues because obviously there hasn't been the same patient flow go through, so you don't have so many patients. But equally, I couldn't say at the moment, hand on heart, it's because of that. It's something we're still looking at.
Okay.
But I think it's something that our provider colleagues are well cited on as well. So we're actually in discussion about this. What does it mean, etc.
Okay. Thank you very much. So in the absence of any other questions from anybody else, we'll receive your report and we'll let you get on.
Thank you, Chair, and I will return. Just in case any colleagues do have any questions, but they haven't felt that there's the time to ask them of me, as always, I'm always happy to take questions outside of the meeting.
Okay, thank you very much.
Thank you for now.
Your report's received, and see you possibly later. Okay, thank you very much. Right, so back to the finance report to you, Mark, for the 4 months up to the 31st of July.
Okay, thank you, Pos. Can you hear me okay?
Yeah, absolutely.
Great, good. So I'll split the finance report into 2 parts today. I think the first part is the finance report that came out with the pack. And then secondly, I'll just give you an update on some emerging information about the latter half of this financial year in months 7 to 12 in particular.
Yep.
So the paper that came out with the pack sets out the finance report for the first 4 months. By way of context, you remember from the last meeting that we were in a temporary financial regime, which in effect gave us a reduced allocation, but allowed us to apply for monthly top-ups to our position and to our funding. I'm pleased to say that for the first 4 months of this year, we've successfully applied and received top-ups to our allocations, and therefore this position, which was previously showing a overspend of 3.2 million, is now in a balanced position for the first 4 months of the year. So that's a positive position to be in. We've worked very closely with colleagues in NHS England around justifying our levels of spend and worked with the analysis that's required. So positive position for the first 4 months. We also know that the same regime will apply for month 5 and 6. So we will continue to work with retrospective top-ups, and we've actually applied for our month 5 top-up already at a similar level to those that we sent in for month 4. So we're not expecting any queries that we can't manage in terms of month 5, and indeed at month 6 once we do that for the end of September. So that's really the position for the first 4 months, and also the anticipated position for the next 2 in terms of August and September. The second part of the report really is around what happens then from month 7 to month 12.
Can I just interject there?
Oh yes, of course.
Any questions in relation to that pack bit of information, folks? While people think, can I just ask one thing in relation to continuing healthcare? Mm-hmm. Has that been impacted particularly by the COVID situation? Because it's difficult to ascertain whether we'd be expecting higher, lower, or the same sort of level of spending on continuing healthcare, which is, to my mind, is fairly sort of long-standing, effectively almost like planned care, sort of part of our commissioning work. is there anything to note there that we need to sort of look at in relation to potential later COVID impact on CHC?
Yeah, so I'll explain how CHC has changed from the beginning of this financial year, and that will set a bit of context. So traditionally, CHC patients would have been assessed more or less immediately, and they would know whether they were continuing healthcare patients or not. For the first 6 months of this year, what has happened is that the patients have been placed under the care of a hospital discharge programme, which in effect means that the NHS has been funding that care prior to an assessment being carried out. And that's because the CHC assessors have been busy ensuring that we've got discharges acting in a very fluid way to help the flow of patients through hospitals and effective discharges during the COVID period. What that means is that there are a number of patients for that first 5 or 6 months of the year that haven't yet been formally assessed for CHC. So when those patients are assessed, there'll be a mixture of those that are eligible on an ongoing basis, and there'll be those that are no longer eligible, and then we'll revert back to their normal funding stream, which might be by the local authority or might even be self-funded. So that's a long answer to a short question, which is, can we work out the impact on CHC at the moment? Until we work through all of that backlog, it's difficult to say. We do know that there's an increased cost which we've reclaimed through our top-up process for the hospital discharge programme. We're anticipating that once those patients are assessed, we'll have a cohort that will no longer be NHS funded, but at the moment we're having to make an assumption about what that percentage split between those categories is.
Okay, and you've made that assumption and it doesn't warrant particular flagging for risk or anything like that?
Not at this stage. We've included it in our forecast for the remainder of this financial year, and the continuing healthcare team are expanding in order to work through that assessment process, because it's in all of our interest to get those patients assessed as quickly as possible.
Okay. Question from Michelle?
What I worry about that, and I might have just misunderstood, but what does that mean for patients? Because if they've been on the hospital discharge programme and been funded, but then if they have to go back in or whatever, and then come back out again, and then they're not on that programme, then how is that going to be explained to them? Because to them it will be, well, why could I have it the first time and not the second time? I don't understand what the communication would be.
So every patient, when they first embarked on the hospital discharge programme, was given that information and explained that it was a temporary measure, and that was solely in place until the assessment process kicked back in. So I hope that every patient understands that, but if there are any queries, then they generally flow through to the CHC team. They're able to answer those, but it'd be interesting to know if you get any feedback on that, Michelle.
Yeah, okay, thank you.
Okay. Dave, then Andy.
Thanks, Chair. It might be helpful for colleagues if we bring something back later in the year, because Diane's busy leading a piece of work just to describe how we do this now. It's early days, but as we get further into it, it might help us all understand the position. So not just the financial position. I think, Michelle, your point's really well made, what it actually means to patients, clients and the families. So once we're into that, possibly later this calendar year or early into next calendar year, we might get Diane to bring a paper.
Lovely. Okay, thanks. Andy?
I just wonder if Mark could just briefly cover off any impact that the efficiency programme may be having on our long full year's budget.
Yes, so within the pack, we've deliberately included the full suite of reports, and included in the pack is a breakdown of where we are in terms of efficiency. So there is an element of efficiency that we have been able to deliver, that was part of our original plan. There are some elements that are continuing and ongoing through the second half of the year, particularly around prescribing and estates work, and there are other elements that have had to be paused. Now, those areas that have been paused are reflected in our forecast for the rest of the year. So we've been quite transparent with NHS England around what can and cannot be delivered.
and that features as part of our top-ups in the first few months, but also features in our forecast for the second part of the year when we're planning what that looks like.
Okay, thank you.
Okay, thanks. Okay, so we'll let you crack on now. Thank you.
That's all right. No, very good question. Thanks for those. The second part of the year is slightly different in that rather than having retrospective top-ups, we were allocated a financial envelope or an allocation sum. And what's key in the difference for that allocated sum is that it's for the ICP as a whole. So therefore it covers the 4 NHS organisations in particular that are allocated to our ICP, namely ourselves, North Tees Trust, South Tees Trust and Tees Esconway Valley. We got that information towards the end of last week, and we're currently working through the implications of that to see how that fits with our respective forecasts. So you'll understand that each of our organisations will have had a forecast position, and just as Andy asked about our efficiency programme, equally each of those other organisations will have had a similar position where they've been able to deliver some efficiency, but probably not all of it. The next stage is to look at what that shows for the ICP as a whole. So is the envelope sufficient or is it not? And there is a decision point over the course of the next few weeks about how we break down that funding across those organisations. Once we've got to that point, it's likely that we'll need to bring that back for a governing body discussion and agreement about how that will split across the organisations. And those individual trusts will also need to take that through their trust board. Traditionally, we'd have had the allocation to an individual organisation, but right now we've got it as a ICP, which I think underlines the system way of working that we're looking forward to as we move forward for the rest of this year and into next year as well. So that's what we know so far about the month 7 to 12 position.
So you've mentioned 4 provider trusts. Did I miss hearing about CDDFT, or are they covered by a different ICP area?
Yep, thank you for clarifying that, Pos. The position we have is that each, in the world of an ICP, each provider is allocated in full to one of those ICPs. So for us, Tees Esconway Valley is allocated to the Tees Valley ICP, even though we recognise that some of those services operate further south into Yorkshire and also further north into the central ICP. Equally, the opposite way around to that is that CDDFT look after our patients in Darlington. But for the purposes of this funding stream for the second half of the year, they are allocated solely to one ICP. So for us, it's Tees Esconway Valley. CDDFT is allocated in its entirety to the central ICP.
So can we be assured that our Darlington patients are sort of adequately, sort of effectively financially provided for the next 6 months?
So we are working alongside colleagues in the central ICP to understand that, and the first of those sessions will be on Friday this week, where we'll get a better understanding of how they're working with their system envelope in the same way as we'll be sharing how we're working with ours. So we'll get assurance through that route. But at the point at which we bring the discussion back to governing body, we will build that into the discussion as well.
Okay, thank you very much. I see Craig and Janet have joined us. Anybody else wanting any? Karen?
Sorry, I can never get used to the mute thing. I just wondered, Mark, I mean, clearly the acute trust, and you've alluded to it in your report, gearing up to get through the backlog and the additional clinics and everything that goes with that. And I guess that's part of that discussion around the ICP funding, is it, as to how that is managed across the ICP in terms of financial risk for all of the organisations concerned. I just wondered how big a risk that is, and are you clear about that yet?
So Craig mentioned earlier some of the information on performance, planning for the winter and workforce issues. We are working almost to triangulate those issues against the financial position. So each of the trusts has built into their forecast almost getting back to normal as best they can in terms of activity levels. And therefore, when we're allocating or determining how to allocate some of those finances, it needs to take into account the forecast as best we can know it. Now, what we have to bear in mind is some of the points that Dave made earlier around the increases in the R rate and what that may look like. So we're trying to be honest and realistic about what can be delivered alongside the levels of activity and the workforce that's available, taking into account all of those requirements around the potential spike that we're seeing.
So you've got your crystal ball polished.
Feels a bit like that sometimes. It does feel like that sometimes, you're right. Yeah.
Thank you.
Okay, so any other questions or information needed from Mark, or we receive the finance report? Yeah, so thank you very much, Mark. And we received the finance report. And now we've done the Gene bit, so we'll skip over to governance assurance and risk report from Jackie.
Is it me or is it Craig for performance?
Craig, do you want to do that now, or yeah, are you needing to?
I can if you'd like me. If you'd like me to, Chair, I can. That's not a problem.
Yeah. Okay. Sorry, Jackie, you're looking.
No, I'm just confused in case I'd read the agenda wrong. Sorry.
No, we moved Craig down because he was going to another meeting, you see.
Right. Okay.
Yeah. We'll stick to the agenda if that suits you, Craig. If you need to go to another meeting, we'll let you go next.
Thank you. Cheers, Chair. I'll crack on with the performance report now then. Brilliant. Okay. So members should have a copy of the performance report included within the pack. It was a PDF presentation similar to the style that we've been delivering over the last couple of months as we've worked through our COVID response and the various phases. The latest report is dated September 2020, but details the position in terms of performance metrics up to July, with a significant number of the metrics actually reporting the June position. In terms of where we are at the moment, what I was hoping to do is run through our current position with the phase 3 requirements and the responses that we've put in place across our acute and community providers, the independent sector and with our mental health providers, and then touch a little bit on performance and reflect on where we are in terms of the pause to some of the activities that we would traditionally have undertaken during the summer period. So in terms of our recovery planning, we're well into progressing the phase 3 response at this point in time, and the expectation is that between August 2020 and March 2021 we'll have responded to all of the asks set out within the phase 3 letter. Just by way of a summary, some of those asks included restoring all of our cancer services to full operation, so that's full operation pre-COVID, recovering the maximum amount of elective activity possible between now and the winter period to put the NHS in the best possible position as we move forward through the winter and into the new year, to restore service delivery in primary and community services, so to get back to as near as normal as is possible, expand and improve mental health services to support all of our people with learning disabilities and or autism, continue to follow good practice that we picked up during the COVID period. So that's locking in some of the innovations in relation to things like the use of virtual consultations, video technology, etc., that we made use of during March through to the July period. Preparing for winter, so establishing some of our winter preparedness arrangements, the inception of a Tees Valley A&E delivery board, a flu program to vaccinate an extended number of people as we head into this winter, and to launch the Think 111 First initiative, the national initiative, which locally we're terming Talk Before You Walk, which is intended to help relieve some of the pressures that we would anticipate seeing in any normal winter on our A&E departments, but also help ensure that patients are directed to the right place first time, and therefore hopefully also relieve pressures on primary care and other points of delivery too. We've also been asked to continue to focus on our workforce and ensure that we've got an appropriate workforce in place ready for the winter period, and that the workforce is appropriately supported. And Judy Bailey's already touched on some of the recommendations and requirements of the NHS People Plan, so we're continuing to progress that. Health inequalities and prevention, with a big focus on the prevention agenda as we move forward. And then Max just touched on some of the financial arrangements within our integrated care system. So in terms of where we are with our acute and community providers, just touched on what some of the planning requirements were, but in terms of some of the activity trajectories and targets, there was asks to get our activity back to certain levels, which were based on the pre-COVID rates of activity that we would have undertaken. We've worked with all of our providers to try and get back to as close to 100% as possible. That's not necessarily been possible across all of our activities, in part due to some of the restrictions that have been placed on the providers in relation to the COVID response and things like infection prevention and control. So there has been a need to reduce the number of beds that are available in some hospital settings, and also to change the way that we book and manage patients as they travel through a hospital setting to support social distancing, etc. But we have come very close to those levels that we'd seen historically, and indeed we've just last week submitted a revised set of plans that take us even closer to getting to 100%. So the figures quoted in the report today are actually based on the first draft submission that we'd submitted at the beginning of September, and I can share updated trajectories with the governing body after the meeting today. In terms of the financial arrangements, Mark's already touched on that, so I won't go through that any further, but there is some more detail in the slide pack as well around where we are with our acute and community providers. In terms of some of the key points of delivery, outpatient, selective and diagnostics, we have worked to embed some of the innovations, so things like clinical triage of referrals, advice and guidance to GPs, virtual consultations. We've tried to do as much of that as possible. And we're continuing to support our providers to offer more virtual appointments wherever possible, recognising that not all of our patient groups, not all of our population are able to access services in that way. So we need to be mindful of that and ensure that where patients can't access virtual clinics, they are still able to be seen on a face-to-face basis. In terms of our elective programme, we're continuing to look at making the best use of all of the estate that we have available to us. So that includes not only making better use of the independent sector, but also maximising facilities like Hartlepool Hospital, where previously we perhaps haven't made full use of that estate. There's also work ongoing to make better use of the Friarage Hospital in Northallerton as well, and that'll help support some improvements in terms of access to ophthalmology services, in particular cataracts, and also some of the diagnostic services that we provide as well. And that elective work is progressing across all three providers, so County Durham and Dalton Foundation Trust, South Tees and North Tees and Hartlepool Foundation Trust too. In terms of diagnostics, we've continued to work with all of our providers to look at standardising some of our pathways, so in particular radiology and referral guidance for both CT and MRI to help ensure that we get appropriate referrals in, and then we can manage patient pathways off the back of that. We've implemented the GP fit testing, which again takes some of the pressure off the acute trusts and the labs. And then there is lots of work going on to look at how we can increase capacity across various other diagnostic tests as well as we move forward into the winter period. I did touch on our IS providers. There is a separate slide on page 136 around our IS providers. Just a quick update there. We have been working collaboratively with the IS providers and the foundation trusts to make sure that we can maximise the capacity that's available there. We've looked at some new revised processes and pathways to help make sure that we're able to book patients in the most effective way, and that we're not seeing appointments go to waste because they're not being fully utilised. There is a new set of heads of terms for the national contract that's now in place, which helps ensure that we've got access to the capacity that's available out there, and up to 75% of the capacity available in each of our independent sector providers is now available to the NHS to make use of, with around 25% being available for the IS to use for their own work. If we return to a peak surge, then there is the opportunity to look at using that capacity differently and potentially increasing the 75% available to the NHS up to a higher level, but that would very much be dependent on further peaks in COVID. Moving on to mental health, the next slide details a number of phase 3 priorities that we were asked to respond to, and as you'll be able to see, we've made good progress in all of those areas, with examples such as the Tees Valley IAP service being fully operational, the 24/7 crisis helplines being in place right across Tees, including a single point of access, and a number of other developments that have helped support ensuring that we're in the best possible position as we move forward. We've also continued to work with our main mental health provider, TUV, Tees and Esquire Valley, our Foundation Trust, to ensure that we've started to consider what the future impact of COVID might be, not only on our workforce, but also on our broader population as well, recognising that we might not see the full impact of COVID from a mental health perspective for up to 5 years' time. That's it in terms of the phase 3 priorities and response. I was going to briefly touch on our current performance, if that's okay, Chair. Just to summarise really that, obviously the report covers the period up to July, and actually we were still in a lockdown arrangement at that point in time. So what we will see is that a number of the key performance metrics have continued to deteriorate during that period, as we've not been able to undertake the number of operations or see the numbers of patients that we would have traditionally liked to have seen. Focus was maintained on cancer and trying to maintain the cancer standards as far as possible, and ensuring that those patients who needed a diagnostic test were able to access one. But other metrics such as the referral to treatment times, and in particular the 52-week standard, have deteriorated significantly, just because of the lack of available capacity during the lockdown period to actually bring patients into hospital and for them to undergo operations. So that's a very high level summary. I'd be more than happy to respond to any questions or queries that the governing body might have.
Okay, so governing body, your opportunity to question Craig. Anybody got yeah, David?
Thank you, Craig, for that very thorough report. And it's great how much effort is being made to try to rectify the very challenging situation, for being mindful of boundaries of patient safety due to COVID and not exhausting our staff. But it is obviously a concern, not just in Tees Valley, but in many parts of the country, the delays for both diagnostics and elective surgery. And as you've just mentioned, towards the end, the number of 52-week wait patients, which is growing up. So really the question is, can we have assurance as a governing body that all is being done, which conceivably can be done, to safely rectify or at least stabilise the situation, and also as far as possible to be equitable for the residents that are served by the different trusts across the Tees Valley?
Yes, that's a great question, David, and I think what I can say is that we're doing everything we can with our providers to make sure that patients are clinically prioritised and that all available capacity is being fully utilised. There's a big exercise just kicked off this week to look at all of the waiting lists. All of our local trusts had undertaken to clinically validate the lists themselves, and then NHS England has established a programme working with the North of England Commissioning Support Unit to look at undertaking a further validation of lists, which will work with NECS independently, and also try to engage with local GPs to provide some support with validating lists. So yes, take your point on board that we had different waiting times at different providers, and we've had different levels of capacity available in different providers. Working through this clinical prioritisation process, we'd hope that we can identify those with the greatest level of need, and we'll be able to give them access to the next available appointment. But alongside that, we're also trying to make sure that our providers work together. So if one's got a shorter waiting time than another, we can look at how best do we move patients or offer patients the opportunity to move between providers based on clinical need, because obviously all of our patients have already made a choice around the provider that they'd like to be seen at, so we can't mandate that anybody moves somewhere differently, but where there's an option to do that and we can ensure that a patient gets access to treatment in a more timely manner, then we'd look to do that as well. So there are a couple of examples at the moment where we've started to progress that shared waiting list or shared PTL type approach, but it isn't embedded right across all 3 of our trusts at this point in time.
Thank you.
Before I bring Janet in, you alluded to patients making choice, and we have had a little bit of soft intelligence coming back clinically, that where patients may make choice that doesn't necessarily work very smoothly. Can you assure us that actually that is being worked on, that patient choice is being delivered where contractually it is a legitimate process?
Yeah, so I think what you're alluding to, Pos, is that we've had some feedback from some of our practices in Darlington that where patients have chosen to access outpatient appointments at South Tees Foundation Trust, then perhaps the referrals have been rejected or queries come back as to why the patient's choosing there. We have picked that up with the provider, and we're continuing to work with them to ensure that they fully understand that patients have a full choice. We are a Tees Valley CCG, they are a Tees Valley provider. So the same with North Tees and County Durham and Darlington Foundation Trust. If we've commissioned them as the Tees Valley CCG, then they should be providing access to services for our whole population. And where that's not happening, if our practices can feed that back to us, our patients can feed that back to us, we can pick that up with the provider.
Okay, thanks. Janet, is it okay if I bring in Dave, or are you needing to come in next?
I don't need to come in because Craig actually said what I was going to say, so that's fine, thank you.
Right, okay, thanks. Dave?
Thanks, Chair. I was just going to reflect the other interesting aspect of patient choice, where we know that some patients are choosing not to come for appointments, which goes back to the conversation we had about making sure we get communications as widespread as we possibly can, because it's bad enough trying to do the backlog, but then if we've got people who understandably might be anxious to come out, we need to be encouraging them to come out so that their conditions don't deteriorate as well.
Okay. Yep. Anybody else got any questions or observations? Yeah, Hassan.
Hi, thanks Craig for putting all this information together. My point is really about cancer. On a recent sort of cancer meeting with the Northern Cancer Alliance, we're still seeing quite low numbers of 2-week rule referrals within the area, specifically for breast and for lung. And obviously that's reflected on in the data you provided here. Is there anything that we're doing as a CCG to try to get patients to seek advice when they get symptoms, especially in light of recent publications in the news for patients assuming that the GP surgeries are closed? Is there anything we can do as a CCG to try to help publicise to patients that, look, if you get symptoms, please do seek advice?
Janet first. Sorry, Janet first and then Craig. Sorry.
We may be about to say very similar things, but I'm receiving frequent communications from Judith McGuinness in the communication team, and we are involved in a programme that coordinates with what's happening across the ICS, as well as obviously from our ICP perspective, stressing to patients how important it is that with their different symptoms they do respond and report them to their GP. We've had something go out today about lung cancer. We've got something planned about prostate cancer and a variety of other approaches to directly target those groups where we know we've seen the referrals drop, and they are in hand at the moment.
Right, Craig now.
Same point. So Janet's covered it off. Thank you.
Covered off. Yeah, lovely. I've got a question in relation to the National Independent Sector contract. My understanding is that the trusts, provided that contract has been being used, it'll be able to run forward to provide the extra capacity to deal with some of the planned care that's potentially been held up. Can you assure us that we're maximising our use of the present level of activity available in order to allow us to maximize future activity?
Yeah, I mean, I think that's a great point. So there is confirmation in place that if we continue to use it, we'll retain it. If we don't have a high level of utilisation, then the contract would be reviewed on a provider by provider or site by site basis. So you're absolutely right there. In terms of our utilisation, we've got systems and processes in place now to ensure that we are booking our patients in an effective and timely manner, and that we're maximising the amount of capacity that's out there. We've worked collaboratively across the entire North East and North Cumbria to make sure that all CCGs and all of our populations have got access to independent sector capacity, recognising that not all of the ICPs have an IS provider within their footprint. So a good example would be North Cumbria, and we've worked with colleagues over in North Cumbria to make sure that there is some capacity available in both the Nuffield and Ramsey Hospital. It's a relatively small proportion of the total that's available, but there is some available, and they're making full use of that. Locally, what we're trying to do is make sure that where possible, we're moving cohorts of patients over to the independent sector providers so that they can work with those patients to book them in. And that's therefore stopping that almost like the piecemeal approach, whereby a couple of patients were trying to be booked in, then if there was a problem with social isolation or availability for surgery on a particular day, then the slot would almost go empty. The IS are now able to manage those patients themselves, almost like their own waiting list, and they're able to book clinics and theatre slots appropriately. So we've got a much higher rate of utilisation now. In fact, we're using up all of the slots that we've got available to us, and we'd expect that to continue right through the winter period, especially in light of the size of the backlog that our local providers are carrying at the moment.
Okay, thank you very much. Any last questions? But on the back of that, thank you very much for the report, Craig, and for the clarifications that you provided. And now we'll move on. That's okay. Yep. Right. Yeah. So we'll move on to the governance assurance and risk report, Jackie.
Okay. Thank you, Chair. This is the quarterly report that comes to the governing body, just highlighting some of the key areas that have been undertaken over the last couple of months in relation to the broader agenda relating to governance. But there are two areas I particularly like to draw out today. One is the update on risk. Now, you're all aware of the work that we've all collectively been doing in terms of developing the risk register and the assurance framework, as well as the discussions we've had in development sessions. Obviously, that will continue to be an iterative process, and we'll continue to try to improve the way we report, the level of information that the governing body receive. But the risk register and assurance framework are provided as appendices to the report today, and they have all been updated by each of the responsible directors. If we've got any particular questions on any of the risks today, then I'm sure the directors will be more than happy to talk through those. In terms of improvements to it, though, indeed at the last audit committee, although I wasn't there, I do understand that the new Audit 1 manager has suggested some further improvements to the way that we report on our risks, particularly the high level risks, and I'm following these up with her. Some of the suggestions include potentially including target risks, separating out and distinguishing between corporate or strategic risks. So I'm looking into that and seeing how we can best move forward with reporting that still meets the requirements, most importantly of the governing body, but that we're reflecting good practice as well. So we'll take that forward. We're also aware that NHS England have recently changed the way that they look at risks and their overall risk assurance framework. We haven't got the detail of that as yet, but it is going to be shared across all of the governance leads in Cumbria and North East in the next couple of weeks. So there may be some learning that we can take from that and that I'll bring back to the governing body, and you may see reflected in future reports if that's okay. You'll see that in the report and in the assurance framework that there is actually a risk included there, thinking about the earlier conversation about the hospital discharge programme. So Diane is taking that forward. At the moment, the initial risk and the residual risk are the same, which is quite unusual, but because it's been highlighted at such an early stage, some of the controls and the actions that will be taking place are not currently sufficient to mitigate against that risk, and that's why the levels are currently the same. But hopefully we should see that reduce as time goes on. The next thing I wanted to raise was the EPRR, the Emergency Preparedness, Resilience and Response Compliance Statement. This is an annual statement that NHSE ask NHS organisations to complete. It usually varies, there is often a deep dive. This time, however, they're focusing in on 3 particular questions in relation to our response to, 2 of them in relation to our response to COVID. On page 1, I'm just squinting there, on page 156, I think it is, 3A, B and C, summarise the questions that we've been asked. The first one, A, in terms of the partially or non-compliant ratings for 2019 and 20, don't relate to our CCGs. The 3 predecessor CCGs were all substantially compliant, and so we're okay with that one. B refers to the CCG either having undertaken or have plans to undertake a formal review of the process of our response to COVID to date, and confirm our compliance with that. Obviously, that you just heard Craig's presentation. There's an awful lot of work being done there in terms of sharing good practice and reviewing what we've done. But similarly, the composite report that I referred to earlier on coming into November will feed into that. So I think we can safely say that we're compliant there. And then the C refers to learning the lessons from that, embedding them in as part of winter planning and also across the system. And I think we've heard evidence throughout various reports so far during the meeting of how we're doing that. So I would suggest that we are compliant with that one as well. That particular return has got to be back with NHS England by the end of October. So subject to governing body confirming whether they're happy with that proposed approach, and they'll arrange that to be done. As an aside to that, not for our statement of compliance, but also practices have been asked to submit a separate return, which predominantly relates to their business continuity plans and processes. And Karen's team are working with practices to help that process go through. So those were the key things that I wanted to raise. I'm happy to take any questions.
Okay, so open to any questions or comments from people? In relation to the last one on practices, are they needing significant levels of support to deliver their reports or not, Karen?
It's brand new for practices, to be honest, Paul. They've never had to complete an EPRR return before. So what we've done is we've worked through the regional return and we've simplified it. But we're going to be having one-to-one discussions with the practice managers. We're going to complete as much as we can for them to what they've already told us, for them to then validate. And then we'll be talking them through some of the arrangements. Most of it should be okay because it's all in line with the standard operating processes, version 3.4 that have been set out by NHS England. So what we need to do, the biggest change probably is that they need to have reviewed their business continuity plans and included how they will put budgeting arrangements with PCNs and outbreak management in place. And obviously if they read that blind without having the information that sits behind it and what we're expected to respond from NHS England without support from us, they may misinterpret it. So we've already discussed it with some of the practice managers and we'll be contacting each practice on a one-to-one basis to complete that and have the returns by the end of October, to make sure that they understand what the requirements are and it isn't just a filling in a return and assuming that it's correct. So we'll have full assurance because we'll have 80 returns.
Well, yeah, great. Is that something that can be sort of for the future done at a primary care network level to facilitate the process?
The requirement is for the GP practices because they're the contract holders and the networks aren't legal organisations. What we are going to do once we've done the returns with all of the practices going forward, if it's a requirement, it should be pretty simple once they understand what sits behind it. Because they haven't done it before, we felt sending out the documentation would be really difficult because they may misinterpret it, and we've seen that before. So we're trying to guide them through this year in preparation for future years, so it should be an easy complete. We will aggregate it up to PCN level though once we get the returns back, and we will be aggregating it up and informing the PCN CDs of their groupings, their constituent practice returns, because there are certainly arrangements if practice advise us that yes, we've got buddying arrangements in place with our PCN and the PCN aren't aware of it, they need to be aware of it. So we need to make sure that it correlates with what the PCN requirements are as well. So we will do that this year, but it's not a requirement.
Okay, thanks. Anybody else want to ask any questions before? I've got one last one for Jackie. No. No. In relation to the risks and their mitigations and the fact that it's not changed much because it's fairly new stuff, when do we need to bring it back to the governing body to look at how the risks have been mitigated? When would you reckon?
The risk, every time I do one of these reports, I will highlight to the governing body if there are any significant changes to any of the risks. So that will be a standard part of this report that comes to every governing body. We had previously suggested that the assurance framework comes formally to the governing body twice per year. In the past, we've had it more frequently than that. I can do it however the governing body would prefer. I'm more than happy to bring it more frequently if needed. But also just to confirm to the governing body that the executive committee do review the full risk register on a quarterly basis as well. So the process is that I meet with each of the directors, we talk through the risks, I update it, it then goes into the executive committee for a full review. And of course, all of the individual committees have an element on the agenda that asks for any concerns, anything that needs to be escalated onto the risk register as well. So we're trying to capture things in various different ways, not purely relying.
Oh, that's good. So I think probably we'd have a sort of, because of the COVID situation, the changing COVID situation, the potential impact of that on some of the risks, I suppose it's a sort of pass on to the exec that we'll have a greater appetite for an earlier bringing back to governing body if they feel it's so necessary at their quarterly review. Yeah. Okay.
Yeah, that's fine. Yeah.
Fine. Okay, lovely. So we received that report. Thank you very much for all the work you've done on that and everybody else who's been involved in that. And we'll move on now to, we've done Craig's bit, Janet's flu vaccinations, verbal update.
Thank you, Paz. I can actually...
oh, there's a presentation as well, yeah.
There is, and I will endeavour to share my screen, Paz.
Yep.
Bear with me, I'm terribly sorry, some technical problems this afternoon.
That's all right, we'll wait patiently. Give us a breather to stretch ourselves.
On the other hand, well, it's open on my screen and I can't get it to share on yours. So I do beg your pardon, I'm struggling, but I'll keep on it.
Yeah, no, that may be because we're not set up for everybody sharing. Lynn, can you do anything?
I did send it through to Lynn. Lynn, is there any chance that you can share it for me? If not, not to worry. I'll start anyway, if that's okay.
Yeah, that's fine.
Yeah, I'll see if I can share it for you. Just bear with me.
Whoever's hosting, if they click on security, should lead to it.
Yeah, understandably, I'm not teaching anybody in the governing body to suck eggs. We know that in the light of practicing under COVID, as we approach winter, the need to minimise the risks of other respiratory illnesses, of which obviously influenza is a significant one, can impact further on services that will be stretched with regard to increasing in COVID. We wanted to make sure that the flu vaccination programme this year we know it'll be absolutely essential to protect as many of our vulnerable patients as we're able to do so, to support the resilience of the healthcare system. And this was emphasised in national guidance, with the first flu letter being released on the 14th of May and the second flu letter being released on the 5th of August. which clearly sets out, you know, what we need to be about. Basically, in principle, we need to make sure that we vaccinate those vulnerable patients as soon as possible, starting in September when the vaccination is delivered, and then aiming to complete the vaccination programme in November. Now, how the vaccination works with when practices receive delivery of vaccinations, some practices have already received vaccinations and are able to administer them to patients now and have been doing for a couple of weeks. But because the deliveries are staggered, some practices haven't started their campaigns yet, and that's not because they're being slovenly, it's because they haven't received the vaccine to be able to start it. But obviously, yes, you know, it's making sure that as soon as they receive the vaccine, they're able to get implementing it and delivering it. We know that it has to be prioritised, that you get the vaccine to those at highest risk of complications and those at greatest risk of spreading the infection, to make sure that you're covering both ends of the influenza spectrum. And the national target that's been cited is to aim to vaccinate 75% of the at-risk groups. Just to re-emphasise for anybody listening who isn't aware of what the at-risk groups are, as in previous years, all children from the age of 2 to 10 aim to be covered under the vaccination. If you're between 6 months and 65 in a clinical at-risk group, or you're pregnant, or you're 65 years or over, or you're in a long-stay residential care home, or you're a carer, or you're a close contact with an immunocompromised individual, or you work within health and social care in a care home or nursing home setting, or with a domiciliary care, or indeed work for a hospice, that the expectation is that you will be covered, as indeed are all health and social care frontline staff. However,
Janet, can you just pause?
I certainly can.
We've just got that on page. Which page would you like up now?
In which case, I think that'll be page 4. If we aim for page 4, Lynn. Sorry, thank you for that pause. This year, as has been announced by the government, they recognise that the need to have a really effective flu campaign has caused them to increase the cohorts of patients that we would want to cover with our with flu vaccination. So in addition to the groups that we've mentioned, they have also widened it to cover additional Year 7 students. They've widened it to include anybody who is in receipt of a PA who has a personalised healthcare budget, and they have also talked about, that has been covered widely in the national media, that they would aim to cover patients who are aged between 50 and 64 and aren't in an at-risk group. But obviously, yes, that is a significant cohort that wouldn't have been previously accounted for, and they have made it quite clear, possibly not as much in the media as has been in the national guidance, that is to be if vaccine supply is available, and that is to be a phased approach to enable us to cover the most at risk first, and the vaccination for the 50 to 64-year-olds wouldn't begin until November, pending the availability of vaccine. If you can move on to the next slide, Lynn, thanks, if that's okay. Sorry, thank you for getting onto that one.
If you carry on, Janet, and then Lynn can keep up.
Don't worry, it's just I'll have to change screens so I know where I am myself. Understandably, with the target of 75% vaccination of the at-risk groups and those that the government now have as eligible for vaccination, there is a complexity because practices do not have access to 75% of vaccinations. They have attempted to order more from the vaccine suppliers and have not been able to do so. However, we do know that there are nationally held stocks. We are expecting guidance in September as to when the nationally held stocks will be able to be released, and to whom they will be released. We do not have that information as yet, but as and when we receive that information, obviously, yes, we will incorporate it into our plans on a Tees Valley basis to make sure that we can have access to that Tees Valley supply as best we are able to do so. And I do beg your pardon, I'll just have to try and change screens because I need to keep up with my own slide.
Right, Janet, I'm sharing my screen with the slides, so which I'm on page 6 at the moment.
Yeah, if you can go to slide 7, Paz, thank you.
Yeah. There you go.
And go on to page 8, please.
Right.
Okay. Understandably, an important part of the flu campaign is to reduce those who potentially spread it, as we've said, as well as those who are at greatest risk of complications. Hence why it's really, really important that all frontline health and social care staff are vaccinated against flu. This is because some of them will be in the at-risk groups and indeed, you know, could become unwell themselves, but it's also to make sure that we minimise the spread to our vulnerable patients. Next slide, please, Pos. As we've mentioned, there are nationally held supplies that will be able to augment the supplies that are currently sat in practices and across community pharmacies. Next slide, please, Pos. Understandably, from a CCG perspective, we need to make sure that we are monitoring how we are doing with our supplies of flu vaccination, so that we are able to call down and draw upon that nationally held stock as and when that becomes apparently a need, if demand has outstripped supply. And we will be monitoring vaccine uptake on a weekly basis to gauge and be able to evidence the increased uptake, so that we are in a position to form a case as to why the Tees Valley would be wanting to apply for those additional national stocks. Community pharmacies do also have vaccine stocks, but it's very hard to determine as to quite the level of stock that they hold, because national chains hold stock at a national level that is then drawn down locally. So it is hard to determine quite how much you have available at any one time. If you can go to the next slide, please, Pos. Understandably, with what we've said so far, delivering the flu campaign this year, it needs to be very, very differently and done differently, and there have been innovative approaches that have been planned. There is significant collaborative working across practices, across primary care networks, GP federations, with community pharmacy partners, community services, foundation trusts, all working together alongside local authority colleagues and with public health colleagues in addition. It is recognised that this year, to have the success from the flu vaccination programme, we all need to collaborate together. It's really important that when anyone receives a vaccination, that is recorded on their patient notes so that they only receive one vaccine, because these vaccines are going to be very precious. And there are now systems in place to make sure that if a community pharmacy administers a vaccine, that goes straight into the GP patient notes. And we are hoping that that is going to be the case for vaccinations that are administered to patients in a secondary care setting as well. From a Tees Valley point of view, we have a flu vaccination board that has been set up and established to make sure that we coordinate our plans and awareness locally. And there's a local flu plan. It's a live document, and that document will evolve as the flu plan and season progresses. Understandably, we're linking in very closely with the regional ICS flu board approach, making sure that we share all the learning. Guidance is changing with regard to some of the elements of the flu vaccination programme to be able to make it logistically easier to deliver with regard to how you are allowed to transfer vaccine, to make sure that, yes, if you are running a clinic and you are short of vaccine, but another practice has it, that you are able to make it so that that patient who's attended does actually receive their vaccine in a timely fashion, which obviously is essential. Also making sure that the contractual arrangements for different practices to work together in innovative ways are made as easy and smooth as they possibly can be. One of the main priorities of our Tees local flu board is to make sure that we identify any gaps. It is essential that we do reach those patients that are at the highest risk, and put in place proactive approaches to reach those harder to reach patient cohorts. We know historically that in the at-risk groups, in the under 65 age bracket, we have not managed to achieve anywhere near the aspirational targets this year of 75%. So there are significant challenges ahead, alongside as is apparent, administering vaccine amongst COVID, when social distancing obviously makes these vaccination programs needing to be delivered in very innovative, different ways. If you can go to the next slide, please, Paz. Thank you.
1 second.
Sorry, thank you. We have in our area a wide variety of approaches that have been adopted, and some people may already be aware of the very innovative approaches being put into place that are due to start on Monday in Darlington. On a town-wide approach with mass flu vaccination on a drive-in basis at the stadium, as well as walking basis within the town centre at Darlington. Very innovative approaches with practices working together to try and make sure that they maximise on getting their patient cohorts through. They've also paid considerable attention to those harder to reach groups as well, especially with regards to travelling community in Darlington. From a Hartlepool perspective, also similar, run by the Federation, mass flu vaccination approaches in the town hall that is currently ongoing as we speak, and the patients are receiving that very well, and the staff are finding it is proven to be a very effective way for this to be administered. Understandably, our flu plans had to be scrutinised alongside the complexities of vaccine supply, as well as the complexities of any impact of a COVID outbreak locally, or indeed any impact from a COVID lockdown situation. Our plans have been stress tested by the military early in September and performed well, although we will need to continue to regularly review the plans as the flu season progresses. Our next flu board is on Friday, as is the ICS flu board in the afternoon as well. Next slide, please, Pos. Understandably, it's no good if people don't know what we expect them to do, and a major strand of the approach to flu has been our communication campaign, and to try and recognise that patients are loyal to the North East, so we are doing our communication campaign across the ICS footprint, which makes eminent sense. And the tagline that we've gone for is the hashtag do your bit, recognising that there are many different elements of the flu vaccination campaign, be you wanting to protect those who are vulnerable from the complications or those who are potentially at highest risk of spreading it. And so that's a theme that has been chosen. Next slide, please, Pos. And just to see how that's one example of with children as to how they could be protected and be a superhero to protect others. It is I suspect though that our big push with media, and indeed Michelle, if it will help, we've got a whole toolkit that has been made available to practices and other partners involved with the flu vaccination campaign. We can make that available to yourself. But the experience so far that I learned about this week from a Hartlepool practice was that normally it would take them 2 months to get their over 65s to come into clinics to be vaccinated against flu. They're going to have achieved that within 3 weeks this year. Now that does suggest that the demand for flu is going to be really, really significant for the flu vaccination, which is what we would expect, as long as that's offset by any concerns about the need to attend a surgery or another service to have the vaccination administered. If you can go to the next slide, Pod, please. That's lovely. Understandably, one of the main pressures with regard to flu vaccination is that flu vaccination cannot be given at the same time as COVID vaccination. COVID vaccination is being developed and clinical trials are underway. This is going to be a nationally delivered programme, but we know that COVID vaccination can't be given at the same time as flu. So it is an imperative that we are as efficient and effective with our flu vaccination programme as we can be, because we need to prioritise those at highest risk to have had the flu jab to also be ready for their COVID vaccination. So it is very, very important that we do progress with our flu vaccination plans, make sure that everyone who's had a flu vaccination is recorded and then is ready and braced for COVID vaccination as and when that becomes available. And forgive me, a definite plug for those patients of ours who are most vulnerable and are at greatest need, and indeed have to mention that because of the significant risks to our learning disability community because of COVID and indeed because of flu, it's so important that we continue to make the reasonable adjustments that are required for this patient cohort. And final slide, pause. Any questions? And I've gambled through that, sorry folks.
Right, okay, so any questions or comments? Andy, were you waving your hand? No, no. While people are thinking, it's particularly worth noting for the record the efforts our primary care practice members have been making to get flu rolled out effectively. And what you've been reporting, Janet, is really sort of useful feedback, particularly for yourself and for the exec team as a whole, in relation to making sure that we secure for the Tees Valley at least a proportionate share of the national stockpile to make sure that we get as many people vaccinated as possible. So please note on behalf of the governing body our support for acquiring as much vaccine as we can legitimately obtain for our practices.
Thank you for that, Pos, and certainly the practices have responded very, very favourably. I appreciate that we don't want to be asking them for more data than is essential. However, we will be collating data on a weekly basis, some of which is available nationally, but there's a bit of a delay with that, to make sure that we are in a position to put our best foot forward for Tees Valley, to make sure that, you know, if there is any availability of that national stock, that we are up there with our requests as to why our population, which obviously has significant health inequalities, would be eligible for further supplies.
Absolutely. Welcome back, Jean. Anybody else, wave your hand if there's any other comments. Yeah, Michelle?
I've just had something come in actually that has said that in the area there's taxi companies who are refusing to take people exempt from face coverings and saying they need a letter from the GP. What worries me is that if people haven't got transport and they're having to rely on taxis to get to the GP surgery, how are they going to do that if they can't, if they're being refused? It's just something to be aware of, that's all. It might just put a spanner in the works for some people.
No, thank you for flagging that, Michelle. And yes, that's something that I will look into for you. I am not aware that GPs are required to produce evidence that a patient is exempt, but I know I'll look into that to make sure that we don't have that as an impedance for the flu vaccination programme. Thank you, Michelle.
Okay, right. So thank you very much, Janet, for that comprehensive report. Interesting things to sort of consider, particularly in relation to the sort of, with a bit of luck, we'll be in a good position, having vaccinated hopefully a lot of people early, for if and when the COVID vaccine comes out, to particularly start with the most vulnerable groups, because they'll be the ones who have been vaccinated first for the flu jab. So that's good news. Thank you very much. Okay, so we now come to the section for information. There's a couple of reports that Jean got so effectively responsibility for. So anything you want to flag, particularly Jean, or just take them for information? The CCG Safeguarding Children and the CCG Children Looked After annual reports. Just take them for information.
Yeah, Chair, these are similar in the sense of the adult safeguarding report that was presented at the in-committee. This is the Durham version of the Tees reports that were presented at last governing body. Tees have done these as an integrated single report. Durham does their slightly different, so that they you've got a Safeguarding Children annual report and a Looked After Children annual report. They are very informative in terms of the work that's underway and the issues for the populations that we serve in terms of safeguarding. Happy to take any questions now or outside of here, noting the time frame, but as you say, Chair, for information.
Okay, thank you very much. So we'll then move on to the Leader Local Area annual report. Yours again, Jean, so presumably similarly for information.
Yeah, similarly, this is for information. Key to consider when we look at this is, I think I heard Dr. Walker referencing under flu some of the vulnerabilities of this particular patient cohort. The North East led the way around about this leader work with one of the pilot sites, and this was a review of patients who had a diagnosis that would classify under various different headings of learning disabilities, and if they had died earlier than you would expect. We actually look at all deaths, and I think it's a good indicator of some of the care that we are now able to deliver, that some of these patients with very challenging health conditions do live what can be considered a, whatever normal is, but a lengthy normal health span. Obviously, some people do have challenges before that. So what we do is, once these patients are flagged, we look at each one and we're looking to see what care did they have, both in any incidence of illness, but over their lifetime duration as well, and the learning that we can derive from that and how we can improve the services we deliver. So I'd just like to bring your attention to the recommendations really. And one of the other key things which we would all welcome and support, when these mortality reviews are undertaken, they're not purely a clinical focus. They do actually take on board the wishes of family members, carers, friends as well. So it's a very holistic thing. It's done with great care and consideration for those who remain. These family members who sadly are deceased have been often very loved and members of the family and very integral. So we're dealing with people who are bereaved. So it's done in a very sensitive way. But can I commend the report to you in terms of the learning and how we take that forward? Once again, just happy to take any questions because it is for information.
Okay, and does everybody support the implementation of the recommendations? Yep.
Caroline, did you have a question?
Oh,
yeah,
Caroline.
Yeah, if you don't mind, I thought it was a brilliant report, Jean, and I wondered if there was on I'm trying to think what page it was. I think it was on page 244. There was a table, and I wondered if there's any comparative data year on year to see if we're shifting the dial on some of this stuff. Because obviously there was that lady that came to our governing body last year and spoke when we did last year's version of this report. And I just wondered in terms of if there was the possibility to report that and see what improvements we're making year on year, particularly in relation to that table 7 and on page 248 as well. The table that showed the percentages of the people that take advantage of some of the screening opportunities. But I thought it was a brilliant report, so well done.
Apologies, Caroline, off the top of my head, I can't give you an answer to that, but I'm happy to take that as actions and to come back to you. I think the other key thing to note on this, colleagues would think, has COVID impacted upon this? Clearly, the clinical capacity across both the NHS and the independent sector has been very focused on COVID. So some of the discretionary capacity to support this has been deployed elsewhere. This is very much refreshed as a high priority. And in addition to everything I've said about the quality of the reviews, we've now got very, very, very strict performance targets to actually undertake these and complete a certain amount by both the end of this year and also at the end of March next year. And within that, there is a specific COVID-19 priority as well to see if patients have been impacted and by the COVID-19, if that's influenced their death at all. So happy to pick up those actions.
Okay.
This for information.
Right. So yeah, Caroline.
Go on. Sorry, just about. I was judging a Women in Housing Awards yesterday, and there was an initiative that got flagged up called Harry's Pledge. I don't know whether you're familiar with it or not, but it was about the role. Obviously, carers have been really impacted by COVID, and it was a list of pledges. So it's definitely worth just Googling it and having a look in terms of what organisations can do to support carers more. And I don't know whether that feeds into this or not, but it would be good if you just had a look at it.
It doesn't actually feed into this, Chair, if I may, but colleagues will be aware through our other carers engagement work that we do as the CCG, but also through the good offices of Michelle and her colleagues, that the carers support that we work collaboratively with our local authorities on as well is a high priority. These patients, many of them have an awful lot of needs, so the carers consideration is the other half of the package around about doing that.
Brilliant.
Thanks, Chair.
Okay, so if we pick up some actions for Jean to discuss in detail with Caroline, and if necessary to feed back to the governing body later, and the recommendations specifically in the report, the governing body support the implementation of the recommendations.
Yeah, can I just apologise for my assistant wishing to join in with the conversation? I do believe she is supporting comments.
Absolutely.
What I would say that I'm in very good company, because having just come off the national call, Amanda Pritchard was joined by her dog howling to be out. So I feel, quite lucky. I am sorry.
No. Nice bit of a break from the length of the meeting. Apologies, I'm running slightly late. Right, we'll move on to the reports from the committee chairs. There's the audit, the executive, the primary care, and the QPF. The relevant chairs are here. Anything to flag? Otherwise, we'll take them. Note the reports. Note the reports. Yep. Okay. Then there's the annual audit letters for the 3 preceding CCGs. Mark, anything to flag there, or shall we just note those, or do we need to approve those?
Just to note them, they've been approved by the Audit Insurance Committee, and they will be on the CCG website as well.
Okay, right, noted. Annual audit letters, Northern CCG Joint Committee annual report. Dave, there's anything to flag from that, or should us to note that as well?
I think it's self-explanatory just to note, unless anybody has any queries, I suppose.
Okay, your opportunity. No, we'll note that. Okay, and then there's sets of minutes from various committees. I won't go through them in detail, so we're receiving those for information. So those are received, and no questions to ask from that. Okay. Any other business? I haven't had any other business noted. Any to raise by anybody at the moment? No. Okay. In relation to this last meeting, iPad person, sorry, I can't remember the name, apologies.
No problems, it's Jonathan.
I'm sorry, I'm really bad with names. So any questions on the matters that we've discussed, or any observations to raise, or anything at all?
No, thank you. It's been very informative.
Okay, I hope you enjoyed it. It's slightly overrun. Apologies. That's my usual track record, but yeah, at least I give plenty of opportunity for discussion and clarity and assurance. So, on that note, I'll wrap up the meeting. Apart from noting the fact that well, we've discussed the risk register in a bit of detail. Anything from the discussions we've had to date to modify or impact the risk register at all? Open to everybody? No, I think that's a no. So we'll leave the risk register as is there, Jackie. Date and time of the next meeting, Wednesday, the 25th of November. Venue and time to be determined. Feedback as well. I think this one actually was easier for me to chair than the previous one. I'm getting the hang of it, and having 2 screens for things makes it an awful lot easier, and a better computer. So on that note, thank you very much, and we'll be seeing people shortly for the governing body sort of debrief development session. Okay, see ya, cheerio.